The other thing I remind myself and residents, like if you're in this caring profession, burnout is almost inevitable. Not only because you are outsourcing part of yourselves and your compassion and other things, but you're also fighting incredibly systemic issues like lack of access. A lot of physicians can't ultimately do what they're supposed to do because of the way our nation's healthcare systems are organized.
Hello, and welcome to Disruptors at Work, an integrated care podcast. We're excited to discuss mental health and medical residencies.
So, hello everybody. I am Dr. Brandy Biglow. I'm special host for today's episode. I'm joined by Dr. Jason Herndon, Director of Clinical Education at the National Register of Health Service Psychologists and the Chief Executive Officer at Integrated Psyche Counseling and Consulting, as well as Dr. Deepu George, Associate Professor at the University of Texas Rio Grande Valley School of Medicine. And so today's guests have an extensive background and expertise in medical education, which sets the stage for our conversation today. So let's get started. First and foremost, I want to thank both of you for joining me without knowing me and really just saying, yeah, I'll do this. So I really, really do appreciate you guys coming on and being open to this conversation today. So the first question is, tell me a little bit about your background and how you're connected with the subject of mental health in medical residents.
Oh, sure. Yeah. I'm Jason Herndon. So for me, I've spent time working in integrated primary care settings and that type of thing, certainly as a trainee, right? Then as a supervisor. And then I also worked for a time outside of medical education and graduate education for psychology
Mm-hmm.
training. And I ran a clinic that was the primary training site for our doctoral students. And so I think I have a bit of a background in thinking through wellness and supporting that and how that impacts both the clinical care and the learning, right, of students who are seeking to be care providers, right, in our society.
Awesome. All right. Dr. George, what say you?
Yeah, I have been involved in medical education for the past several years. I am a behavioral science faculty in my primary
Okay.
role, and I provide integrated behavioral health clinical services as part of our family medicine residency program. With Jason and I also happen to be involved in the Collaborative Family Healthcare Association.
Mm-hmm.
In fact, Jason is the incoming president, taking
Oh,
charge January
congratulations.
Thank
1st.
you.
And I'm the outgoing president. I finish my term in the next few weeks, and so
Awesome.
um, we are a community of integrated care where our membership includes physicians and behavioral health professionals, researchers, policymakers, and so naturally it falls into our membership
Mm-hmm.
um, categories. And thinking about their well-being is another reason why we think about well-being in medical residents or well-being in medical professionals. And so that naturally flows into, I think both of our training backgrounds
Mm-hmm.
influence that a little bit, but also our larger involvement from a national perspective puts us in the crosshairs of that, if you will.
Yeah, absolutely. Wow, that's so cool to meet the ingoing and the outgoing president. So I'll definitely be keeping in touch with y'all because I really appreciate what the CFHA has been doing and bringing the integrated care just forward and just ushering it forward the way it needs to be. Because a lot of people, they kind of like the idea of it, but they don't really understand it. So I'm glad that you guys are doing that work. So second
Yes.
question. What has been your journey in understanding the importance of supporting mental health for those in medical residencies and other healthcare disciplines? Why do you think it's important to integrate mental health into working with specifically mental health residents? I mean, medical residents. Sorry.
Well, I'll take a stab at it. I think primarily when you think about the work that we do as healthcare professionals, whether you're on the medical side, on the behavioral health side, I think the fallacy has been to think that none of this affects us in any important
Mm-hmm.
ways, right? And I think there's this idea that you're a firefighter and the fire doesn't affect you, and I think that could be a assumption to shake off
Mhm.
from our mental models at the go, right? And
Mhm.
then the other thing I remind myself and residents, like if you're in this caring profession,
Mhm.
burnout is almost inevitable.
Mm.
Not only because you are outsourcing part of yourselves and your compassion and other things, but you're
Mhm.
also fighting incredibly systemic issues like lack of access. A lot of physicians can't ultimately do what they're supposed to do because of the
Mhm.
way our nation's healthcare systems are organized.
Yes.
And so the provider often feels very helpless. So it's almost foolish to expect no burnout.
Mm.
And so
Mhm.
it's almost foolish to expect that this is not changing you as individuals, whoever
Mhm.
you are, right? Whether you're in the healthcare as a medical assistant to a physician, it's impacting everybody at different levels. So I think that's one of the reasons why I think we don't have an immunity against this,
Mhm.
and we ought to be focusing on it and taking it as part of our basic human experience of showing up in these
Mhm.
spaces. So that's where my mind goes initially.
Mhm.
No, I love that. I love
Yeah.
that. What do you think, Dr. Herman?
Yeah, I agree with Deepu entirely. And I would add to that, particularly when we're thinking about residency and other types of training scenarios, right? I
Mhm.
think, yes, it is challenging and emotionally draining to take care of other people for a living, right? And
Mhm.
we need to be thinking about our mental health and how our mental health supports that work. And then also a lack of mental health interferes with that work. I think,
Mhm.
too, it's equally important, if not more important, as we're thinking about trainees, right? The process of becoming a person who takes care of other
Mhm.
people for a living
Yes.
is in itself very challenging, right?
Mhm.
There are financial pieces to it, right? There are
Mhm.
systemic pieces to it. It's a lot of work. There's a lot of reading,
Mhm.
there's a lot of practicum, there's a lot of study, right? There are a lot of sleepless nights and early mornings and all of that type of thing. And so I think we also want to think about the impact of moving through a training sequence, whatever that sequence might be, right? And
Mhm.
how that has, an impact on our mental health and well-being as well. And I think too, just being able to talk openly about how we're doing, openly
Mhm.
about how training can be hard, how this work can be challenging at times. Because I think to Deepu's point, there have been, I think probably all of us have had moments where it seems almost like a surprise to say, like, this is kind
Mm.
of hard today, right? And there's just like, oh, can we talk about that? Can we acknowledge that?
Mhm. Yeah.
And so I think just being able to also be open, right, about like
Mhm.
this work is challenging, right? It can be draining, it can be thankless, it can be tiresome. Being able to
Absolutely.
be clear and transparent about that is also, I think, really important.
Yeah. So when I think about the reason that I'm asking these questions, it's because there was an article that came out on LinkedIn where there was a medical residency who completed suicide, and he just kind of wrote this note about how it was just really difficult to be in the program, and that kind of stemmed my turn in hosting this podcast. And so when it comes to that and going through this process of being a medical residency, Dr. George, you talked about the impact that it has on patient outcomes. Where do you see the responsibility? I'm gonna change up the questions a little bit. What do you see the role in the trainee programs in trying to tackle or address this issue? Because that was one article, but it's also not something that is, I won't say uncommon, but it has happened enough
Right.
that it might be time for medical programs to pay attention to. Hey, this is really hard stuff. So, what do you think the role is in medical training programs to address these issues that these residencies are having?
Well, I think unfortunate moments like that in
Hmm.
our educational sphere or even like healthcare workforce development histories, um, hopefully is a pausing or an arresting moment for a lot of us
Mm,
involved in it and other programs that really think about it. I think over the last 6 to 10 years, there's
hmm.
been a increasing awareness around well-being.
Okay.
The Accreditation Council for Graduate Medical Education, they changed requirements for duty hours
Hmm.
and all of that
Yes.
several years ago. So
Hmm.
that's all in line with preserving of well-being and wellness for all of our trainees. I think there's a fallacy also in thinking about well-being as an individual phenomena versus
Mm,
a collective and institutional phenomena.
hmm.
What I mean by that is when burnout statistics were coming out a few years ago, there was a
Hmm.
lot of uptake in programs related to like well-being and changes to other than the work schedule, like invest in mindfulness and
Mhm.
counseling and those kinds of things, which are all great. And I'm not
Mhm.
saying none of that should all of that should happen
Right.
all the time. But at the same time, it's almost like saying we have all these complications, so we want you to go and meditate a little bit, but come back to the same system,
Mhm. Mhm.
the same environment that hasn't changed at all,
Mhm.
which is that we resort to thinking about well-being at the individual level. We
Mhm.
don't think about well-being as an issue of a system and
Mhm.
program level changes, policy level changes
Mhm.
to make that well-being more amenable, right? And I'm not even, when I say policy, I'm not thinking big P policy as in federal state. I'm
Mhm.
really thinking at a particular institution,
Yes.
what are the tripwires that we can set in place so
Mhm.
that when people do express a need, that there's a responsive system, not a
Mhm.
suspicious system. There's
Mhm.
a system that hears people out and kind of doses out support, not even treatment, right? Because a lot of the
Mhm.
times, I often remind folks that big stressors
Mhm.
are catastrophic, right? They should kind of blow over and it should
Mhm.
kind of make a lot of things unsettling. What is more dangerous is persistent stressors that are minor, but it's kind of
Mhm.
throughout the daily lives of individuals. I think there are things that um, the um, the institution can do to pay attention to those.
Mhm.
Once a year, checking in with residents, what's working, what's not working, and
Mhm.
kind of making changes to some of those things, right? And so, to me, programs should be invested in thinking about not only what are they doing for individual well-being, but
Mhm.
also what are they doing as a group to take care of their well-being as a whole. And that doesn't mean more modules to do, right? That
Right.
doesn't mean more mindfulness modules or
Yes.
training. It
Mhm.
might mean um, alternating call schedules, or it might mean having more open access to support systems,
Mhm.
or having more support for the residents with families or residents with special needs, right? So there might be a whole host of things that programs can do.
Mm. Very good. Anything to add?
I just want to double down, on what Deepu has said here is, when we think about promoting wellness and how that
Mhm.
often has taken the shape of these are
Mm.
individualized things that you need to do, as though the systems that we exist in, the
Mhm.
workload, the other expectations don't have a direct impact on our wellness. Right. And I
Mhm.
think, unintentionally it sends this message that the reason that you are struggling is because
Mm.
you as an individual aren't doing enough, right? And I think
Right.
that's really something to be avoided when we're thinking about wellness. Right? And I
Yeah.
laugh because it sounds almost like a little absurd, right? That it's like if you
Mhm.
just tried harder you'd be well, right? Particularly when I'm working you to the bone, right? And so
When I'm
I
working you to death.
think
Yeah.
the sort of other piece of that is this sort of what I might just add in is this sense of modeling, right? And so
Mhm.
many of us who
Yeah.
are now at a point in our careers where we are in leadership roles or supervisory roles or that type of thing did not come through programs that gave a lot of attention to wellness, particularly not in any
Right.
systemic or sort of holistic kind of a way. And so it's also thinking through like how are we modeling taking
Mhm.
time? How are we modeling, right? So even if we're going to use a sort of individualized, like you should be taking more time off, you should be getting your massage, you should be drinking a hot cup of tea, like whatever, right? Individual thing we like to
Mhm.
throw at people, right? It's like, do I see you doing that as my supervisor, as the
Mhm.
director of this program, as the
Mhm.
head of this medical system, as the dean of this, school, right? Do I see that, or am I getting emails from you at 3 in the morning, right?
Yeah. That
What
part.
are the messages that that's sending to me around like how you yourself prioritize wellness, right? Or how you
Mhm.
as a leader of this system, maybe you are fine with me taking care of myself, but might that cost me somehow in
Mm.
advancement or regard or anything like that if I'm not up doing the same thing that you were doing? And so I think again, right, we unintentionally send these messages with our
Mhm.
own anti-wellness behaviors, right,
Yeah.
to folks who we're encouraging to take better care of themselves.
Yeah, you guys are speaking my language. I did my culminating project on burnout, and you are saying the very thing that was so evident in the research that I did, where a lot of times a lot of the programs and a lot of the models are talking about are putting the pressure on the individual to take care of their health when it is in fact the systems and the processes that are in place. Like you said, Deepu, that okay, you can go away and meditate, but you're going to come back to the same crazy system, and that really doesn't help. So when it comes to that, and you guys being in the positions that you are in, what do you think is needed to get people to listen, because burnout is costing the healthcare industry $4.6 billion a year, and it is not slowing down. And this is before COVID and after COVID. So what do you think needs to happen in order to get people in these higher positions to open up their eyes and say, hey, we really do need to pay attention to the training programs, but even those who are coming out of those training programs, so that we can provide the best care possible for the patients who are seeking services.
I think I would say that it starts with, as you said, kind of listening,
Hmm.
right? And so I think we fall into this hole in academic and healthcare kind of
Hmm.
settings where we love a survey, but we don't love to actually read the answers,
Mm,
right, to
hmm.
said survey. And so I think a part of it is asking folks like what they need. I will
Mm,
never forget sort of being a director of my clinic and talking to some of our students, right? And then you always have this sort of mandatory, like, you aren't taking care of yourself well enough, so we are mandating that you come to this
mm.
very relaxing 2 hour presentation on burnout prevention, right? And if
Yeah.
you aren't there, you're going to be punished in some way, right?
Hmm.
And I think a part of the listening is understanding like exactly what folks need. Because I remember talking
Hmm.
to a student of mine, and her saying, I don't need a massage. What I'm
Mm,
feeling overwhelmed by is that I don't have time to go to the grocery store. I don't have
mm,
time to do laundry,
mm,
right? Like, I don't have time to take my dog to the vet, right? And so it's like I don't, and it feels frustrating to me to hear this idea that well, really what I need is to take a nap, right? And it's like a
yeah.
nap is so far up the luxury ladder, right,
Hmm.
for me at this point, and so it feels almost offensive, right,
Hmm.
when I get this idea that's like, well, you're just not, where's your massage subscription, right, and that type of thing. And so I think in part it's listening to figure out like what is it that people need, and then being open, as Deepu mentioned in his previous answer, to making some of those systemic level changes, right, because the answer so rarely seems to be we will work you less.
Mm, that part. Anything to
Yeah,
add?
I think I think so. One is to think about maybe like listening and working less, and how to kind of create that more um, a friendlier environment for people to work in. The other one is to think about, okay, if you are asking your workforce to take care of the dire needs of a community, like if you're
Hmm.
working in a federally qualified health center, it's just like the demand is so high. But on the back end, what are
Hmm.
you doing so that when people are extending themselves to do the work that is
Hmm.
demanded of the public, what are the bandwidths that you're giving internally to your staff
Hmm.
in order to, it's almost like the what are the buffer systems that you're putting in place, right?
Hmm.
So I often think about how do you design communities of well-being where the principles are more based on human-centered design. And what I mean by
Mm,
that is just kind of thinking about, does your policies put people first or does it put outputs first, right? So
mm, hmm.
if you're kind of, if your policy is based on metrics of the number of patients seen and other things, but you're not really looking into how that's happening, then I think that's problematic, right? And so
Hmm.
I think about, if you look at big industries like Google and other tech centers,
Hmm.
they often have very employee centered or human centered
Hmm.
principles at play. And I know my good friends in the Community Health Center of Central Washington in Yakima, Washington,
Hmm.
they've done this with their behavioral health
Mm,
consultant team.
hmm.
Dr. David Bauman and Dr. Bridget Beachy, they have an amazing internal behavioral health team that runs their team, and they work really hard. They see a high volume of patients. They do a lot, but they also take care of their BHCs on the back end, right?
Mhm.
So things that they do is making sure that they have time in their week to chart, just to kind of work on notes and charts and other stuff. I
Mhm.
think they get 10 or 20% of their time as passion projects. So all the
Ooh, nice.
BHCs get to work on something that brings them a sense of joy. And so we follow a lot of those principles here. In our team is very little.
Mhm.
We have a people first policy, which is the idea that we care more about what you do for my team and our team
Mhm.
than what oh no, we care more about you than what you do for our team.
Mhm.
So whatever you need becomes priority, right? Which is you as a human being. Secondary comes like the professional stuff. What we've noticed that is when we are invested in each other that way,
Mhm.
the productivity and the pressure to perform is no longer a pressure, but it's something that you're willingly ready to give, right? Versus
Mhm.
when you're constantly demanded from, but there's least investment in you or less investment in you, then it's gonna kind of not. You're not gonna be very happy when they ask you for something extra.
Mm, for
Whereas
sure.
otherwise, when you feel invested in and commonly held, you're likely to give more.
That's exactly
Absolutely.
right. Yeah, I think too that there's a we would love a world where everybody cares about humans, right?
Yes.
And we have some folks who feel inclined to care more about dollars and cents. But I think another frame of looking at what Deepu was talking about is through the lens of retention,
Mhm.
right?
Mhm.
And so, like,
Absolutely.
what does it cost us to
Mhm.
replace folks who get burnt out or feel like the
Mhm.
system does not care about them, right?
Mhm.
And so they resign, they leave,
Yes.
right? They have to withdraw for medical or mental health reasons or whatever
Mhm.
happens, right? And I was just looking this up the other day. It is something like on a good day, six
Mhm.
to 9 months of a person's salary to replace them,
Yes.
right? And
Yes.
that's on a good day,
That's on a good day. You are
Mhm.
absolutely correct. And even in our field of healthcare, where you used to have people who would stay in healthcare for 20, 30 years, now you have people staying 3 to 7 years. And I'm like, and I'm my profession is a licensed mental health counselor. I'm barely licensed and I'm quitting. So the writing is on the wall that if we don't take better care of our people, that what we're seeing already is not is going to be even more of a crisis. So in kind of we've kind of come out of the medical residency part, but that's okay because I'm down with that. We could talk about this all the way around. At the same time, I wanted to ask you specifically, when you guys sound like you are doing a really good job in your organizations as far as listening to the people that work for you, and it sounds like you have some connections with others who are listening to their people. What advice would you give to training programs who are looking to integrate mental health support into their for their residencies into their curriculum, in a way that it's not that extra burden that you Deepu was talking about, like another module or something else? Like, what is your advice to those training programs who really do see, hey, we want to take care of our people, but we also recognize that they also need these trainings and these things, so that it's not a burden?
I think all residency programs are guided by the Accreditation Council for Graduate Medical Education, or
Hmm.
ACG. Every single residency programs has expectations within their competencies and milestones around personal well-being that is tied to professionalism, team-based care, communication, patient care, medical knowledge, all of these things, right?
Hmm.
So for residency programs to prioritize and make this a core component of routine training didactics is not a big stretch. The
Okay.
question is, are you willing to bake this into your core curriculum?
Okay.
Almost, if not all, I know definitely for family medicine, you are required to have dedicated didactic learning time.
Okay.
And you have essentially in family medicine, your residents complete a 3 year training program. And a lot of programs fall into this pattern of an 18-month curriculum that rotates twice. So it hits
Hmm.
the 36 months that they are in training.
Hmm.
And so including components that are focused on resident as a person, resident as an individual, can easily be done. part of this is your medical knowledge too, right? Like
Mm-hmm.
understanding what are the wear and tear that occurs to you as a provider in a healthcare system that is guaranteed to burn you out. You ought to be
Mm.
aware of what is hitting you and how do you take care of it, as you are trying to heal yourself in the process, right? So that's one thing to think about. The other thing is, there are lots of ways of using reflective practices and
Mm-hmm.
bake it into routine, again, curricular process, not as a add-on or a separate
Mm-hmm.
thing that you stay after for the last several years, we've been doing something called narrative medicine, which is a
Mm-hmm.
time where we use poetry, prose, pictures, videos, music. As it's not something I invented. These are
Mm-hmm.
all like existing things out there. Dr. Rita Sharon from Columbia University pioneered narrative medicine, and so it's a thing out there. It's a way to help healthcare professionals reflect on their complicated lives as physicians and as individuals. And so we do that once a month with
Mm-hmm.
our residents, and it's
Very
time where
good.
they actually think about their lives outside of being a physician, but connected to their role as physicians.
Mm-hmm.
And they do reflective writing, sharing, and that opens up a lot of principles of universality, which is I'm not the only one thinking about these things. There is a group of people that have perspectives on this. So it could be one issue, but you walk away with 14 different perspectives
Mm.
as people share and engage in different topics. So I think placing a demand on programs to think about, look at your curriculum, the things that we're asking you to think about in terms of mental health is not alien to what
Mm-hmm.
you're supposed to do, whether you're a surgeon, whether you
Mm-hmm.
are a family medicine doc, whether you're a pediatrician in training. Everybody is required to produce competencies that allow people to become the best versions of themselves. And that includes their medical knowledge and patient care skills. And I would say how they look after their well-being shouldn't be any less in that totem pole, right? It should be at a pretty equal scale or equity as much as other things are required of them.
Fair. I love it. Anything to add to that, Jason?
Can't say it any better than that.
That's awesome. Thank you guys. I really, really appreciate your insights on this. I mean, we could talk about this for forever because burnout is my jam, provider wellness is my jam, but we were asked to keep this to a certain time limit. So, on that note, I want to say thank you for being my guest today and sharing your insights and sharing your expertise. I really appreciate you coming on and sharing with me. And with that, until next time.
If you enjoyed this episode, don't forget to subscribe and share. Let's keep disrupting healthcare together. Until next time.